Good afternoon and welcome, and thank you for joining me today for another Leadership Dialogue session. I'm Lassiter, President and CEO of Erin Fraher Health, and this year's chair of the American Hospital Association Board of Trustees. I'm looking forward to our conversation today as workforce is an issue of primary focus and concern for our nation's healthcare leadership. It's an issue certainly that we cannot spend enough time talking about. And as I chat with colleagues across the country about top priorities, I consistently hear that it's workforce. And so we're going to spend our time today on that very topic. For those who have been following along and joining us for our monthly discussions, you'll recall that a couple months ago, I had the privilege of spending time with Debbie Hatmaker, who was the chief nurse officer for the American Nurses Association enterprise, about the nursing shortage. And we had a great conversation about the past, the present, and the future of nursing across our country, and what challenges we face and what opportunities that lie in front of us. So today, I'm pleased to continue the discussions on workforce and have the added privilege of talking with a workforce expert, Dr. Erin Fraher. Dr. Fraher will offer a more global look at the trends in healthcare workforce and share her research and insights on the challenges of current and our evolving workforce. Dr. Fraher holds a joint appointment as Associate Professor of the Department of Family Medicine and Research Associate Professor in the Department of Surgery at the UNC School of Medicine. She is also the director of the Carolina Health Workforce Research Center, one of 5 national health workforce research centers in America. The center provides impartial, policy-relevant research that answers the question, what the healthcare workforce needs to ensure access to high-quality, efficient healthcare for the U.S. population. Ann's recently presented her research at our AHA annual meeting last month, and because it was met with such great interest, we thought it would be great to have her come back. And thankfully for us, she was willing to spend some more time. So we've invited her back to join us today, and I really look forward to the conversation that we're going to have. So Erin, let me just thank you again for joining us and for being with us for this session.
Thank you for having me. It is a pleasure. Workforce is, of course, the most important topic, and to have the privilege of coming to discuss it with you all is a terrific honor. So thanks for having me.
Well, so let's jump into our conversation today, and let's just start with your research. Maybe you could just take a few minutes and just share with us what are some of the trends that you're seeing impacting the healthcare workforce, both pre and post pandemic. Issues around care modules, location of care, telehealth, other trends that you're seeing.
Yes, right, it's really interesting. A lot of the trends that we saw before the pandemic basically you're seeing them again post-pandemic. And what you're seeing is an acceleration and an amplification of existing trends. So things like we were going to face a nursing shortage before the pandemic hit. And in fact, the pandemic has amplified it. We had a maldistribution of providers. We didn't have providers in rural areas. We didn't have them in severely underserved. Again, you saw that, right? When COVID would hit in waves in underserved areas, you would see places that just didn't have the workforce needed to support them. We had a behavioral health and substance abuse crisis in terms of not having the workforce needed. And with behavioral health needs now skyrocketing with the pandemic, we're seeing increased demand and decreased supply, in fact. So a lot of these trends we saw before the pandemic hit, and now we're seeing them, really just in just glaring lights. And so for me, I think that's the message I want to send is these were problems that existed before. Now, there's some things that I would never, as a health workforce researcher, predicted. The Great Resignation, I don't know about you, right? That was not on my radar. So, that's something that has hit us like, whoa, is that going to be a temporary resignation, or are those people going to come back at some point? And I think that one of the things that has been really interesting to me is to look at the forces that have continued throughout. So changing payment models. Look, we're moving from this very fee-for-service model where we're starting to think about value-based care. More patients are going to be in risk-based contracts. that is forcing us to rethink teams. We'll talk about that, I hope, today. Think about redesigning our workforce. So that payment piece is been there throughout, right? And then the other thread that I would just sort of pull through here for hospitals is, you were facing competition from corporate players before the pandemic hit. And then the pandemic hit, and these corporate players were able to sort of step in and fill some of these needs. So I think that's another thing that's going to go out throughout pre and post pandemic. So these are some of the forces that intrigue me, right, to look at and try to understand from hospitals' perspective. How does it help? How does it change the workforce that you need from before to post pandemic and then beyond? So those are some of the things that I'm thinking about.
Great. Well, so first, let me just say I really appreciate you highlighting the piece that I think some who are not in our field don't fully understand, which is we're not necessarily facing new trends. We're having an amplification of things that were happening already, and so
Absolutely.
we had yellow dots on our on our radar screens that now have turned red, or we had green
Right.
yellow dots that have now turned fully fully yellow. So I really
Right.
appreciate you sharing that. And I would just say that you posed the question, would I have been one who would have predicted the Great Resignation in advance? And the answer was absolutely not. That's not something that I saw coming.
Yeah.
So as you think about those trends, maybe we can turn our focus a bit more to the future and predictions or projections as we look ahead. How would you advise the hospital field should be rethinking workflow? Should be rethinking job classifications? Should be
Right.
rethinking work design? So talk to us a little bit about that, because I think that sometimes we have a tendency to focus solely on just recruitment and retention without
Exactly.
sort of thinking about a need for reshaping workflow design, job classification, et cetera. So talk to us a little bit about your predictions for the future.
I'm really glad you raised that, because we talk about bodies, right? Are we going to have enough bodies? But the fundamental question is, how are we deploying those bodies? How are we utilizing them to the best possible ability, to keep them happy, to keep the hospital productive, and keep patients healthy and well? And so, one of the things that strikes me, and remember, I'm a health workforce researcher, and I'm a researcher, so sometimes I say impertinent things. And one of the things that I will say is, when I look at the way, not just in hospitals, but in primary care practices, the way the workforce is deployed, it can be a little old school. We do things because we've done it that way forever, or we do it that way because that's what the professions told us is the way to do it.
Right.
And so I like to come to these kinds of meetings and ask, if you could engage patients and have them design care pathways and have them design the workforce that they need, what would it look like?
Mm.
And so this is something I had the great privilege of going to New Zealand. I know it sounds it was a great trip, but I actually did work while I was there. And one of the things they do in New Zealand is they do these care pathways to understand sort of
Mm.
where, for groups of patients, say you're chronic disease patients, say you're mental health, behavioral health needs patients, for your primary care patients, sort of, where is there missed care? Where's care not happening? Why was it missed? What is happening in terms of the way that the workforce is deployed, and are they deployed most efficiently? So, for example, for chronic care, are we using diabetes educators? Are we, in substance abuse, are we using peer counselors? And so it's this notion of turning workforce planning on its head, from planning for professions to planning for patients. And so the workflows, and that starts you to think about different workflows, different types of healthcare workers. One of
Mhm.
my favorite examples, right, is this model that comes out of Hopkins, and it's a geriatrics care model.
Mm.
And they designed the care model around the patient. And basically, they said, we're going to care for patients in their homes. And we're going to send a handy man or a handy person in with an occupational therapist and a nurse. And it's a brilliant model, because the handyman goes around with the OT and looks for fall hazards and lighting hazards, and the nurse is there to do the vitals and connect with the hospital. And to me, that's the ultimate definition of a changing healthcare workforce, is sort of designing it around patient needs. The other thing I think would be really important for hospitals to think about in the next little bit, you are not going to have enough nurses. I cannot say that enough times. And so I'm sorry to say it, I study the nursing workforce. You are not going to have enough nurses. But the good news is that we can think about how to more effectively use our nursing workforce. It's a scarce resource. So I would ask your nurses, what are they doing that they don't need to be doing? It came up at the annual meeting. Why are nurses ordering meals? Why are nurses doing certain things in a hospital that they don't necessarily need to be doing? So freeing up the nurse to do what only the nurse can do, and perhaps bringing in more certified nurse assistants or licensed practical nurses or others. And the other thing that struck me at the annual meeting, and I'd really be interested, right, in your perspective, is I think hospitals actually underutilize social workers. We are actually seeing a real growth in some places in the use of social workers, not just to address patient needs around behavioral health interventions or connecting patients with community resources. What social workers also do brilliantly is sort of get in the interface when you're dealing with patient violence, and to be able to be part of that team that's deployed to deal with that, not just a psychiatric intervention, but it's also using social workers, or where you're having interprofessional issues, right? So social workers can get in there as part of the team to sort of resolve some of those issues. So broadly speaking, what I'm talking about is designing care models around teams and around patients, and really thinking about what those groups of patients are and what kind of care they need, I think is really going to be the future, and just using your resources the best you can, and not to be afraid of turning things upside down, right? Because you can do that.
So you've raised a host of issues there that we could talk about for quite a bit of time. I think first and foremost the comment you made about the underutilization of what I'll call the non-traditional primary players on the care team, and you highlighted social workers, and I think it's an absolutely spot on point. Traditionally the social worker is used primarily around discharge planning,
Right. Exactly.
and sort of principally in that sort of care management process, and not in some of the other ways that you identified.
Right.
As you shared that there will simply not be enough registered nurses in America to do all the things that we ask registered nurses to do today.
Right.
Again, I would just say you're spot on. And so the question then becomes, what other members of the care team could supplant the current use of registered nurses?
Right.
And it's an interesting debate. We've moved from using sort of broadly both the licensed practical nurse, the licensed vocational nurse, along
Right.
with the RN, to going to an RN heavy model in many places. And
Right.
the answer was patient safety, patient safety, patient safety.
Right.
And I think we're going to have a really interesting set of trends in the near term around utilizing that entry level of nursing in a broader way, not to mention what you described, which is using certified nurse assistants, medical assistants in broad ways. And so this whole notion of getting our care professionals like nurses, but also pharmacists and other members of the care team to work to the top of their license, and then replace those highly prized, scarce resources with other resources that hopefully can be more plentiful. I think one of the challenges, though, with that, beyond the thinking differently instead of getting out of the traditional box, is that unfortunately none of those resources are in grand supply, and so we don't have an overabundance of medical assistants, or an overabundance of social workers, or an overabundance of pharmacists. And so I do think we're going to have to engage pretty briskly in how do we redesign the work as you described, and then ensure that the pathways to produce the talents that's required is there. And so that's a really, really big challenge. We could continue talking about that, but let me move to another question.
Okay.
Because I know we want to spend a little bit of time talking about health equity, and
Yes.
just say that it is, certainly for me as a personal and professional platform, but obviously for the American Hospital Association and many of our members, removing health disparities and improving the gaps around health equity in communities across the country is of critical importance.
Yeah.
Maybe you could spend a little time talking about how your research has helped shape opinions from your perspective on what we should be doing to more aggressively attack the issues of health equity and reduce those gaps in a more robust manner.
This is such an important topic. And we've been thinking a lot about it, and this was another one of those pre-pandemic topics. We've had health inequities in the United States forever, and they have been amplified by the pandemic. And so I've begun to think about this concept of a workforce for health, to address inequity and to address the social determinants of health. And I want to be really specific about what I mean about a workforce for health. So a workforce for health obviously addresses patient needs, but it also addresses the health of communities, right? The health of populations more broadly, and addresses the inequities between communities as well, right? Because if you have a robust health workforce, we know that hospitals are the primary employer in these communities, that a robust hospital employment keeps a community alive and well. So that's the second piece. There's also the health of our healthcare delivery infrastructure. So unless hospitals and others have the appropriate workforce, they're not going to be able to deliver care. And then I've added this dimension that I hope we're going to talk about, which is the workforce needed to support the health workforce itself. And let me drill into these as they relate to health equity. So a key element we see is the need to diversify the workforce. So anything that hospitals can do to identify diverse talent, recruit diverse talent, and support diverse talent. And that might be through giving them educational supports and loans and grants to be able to create career ladders. If you look at the United States, one of the most diverse workforces is the licensed practical nurse workforce. And often that workforce will go on to become registered nurses who may in fact become advanced practice registered nurses. So taking our workforce, because we are not going to address health equity until we diversify the workforce, because we know that patient provider concordance is associated with better health outcomes. There's research there. We know that it's associated with better communication. So I think a key component of this is the diversity of the workforce. But I also don't want to lose, it's not just racial, ethnic diversity. Socioeconomic diversity is absolutely critical. There was a paper in the Journal of General Internal Medicine pointing out that in hospitals, healthcare workers, low-income healthcare workers, mortality rates were 6 times the rate of higher income healthcare workers, 6 times. So what are hospitals doing and others to support that lower income, low wage workforce in terms of securing their own health? And therefore, you just said it right. If we don't have enough people, how do we support them to address their own health equity within our own health workforce? And so I think that's absolutely critical. And then maternal mortality among Black women is just it's just terrible. And so if we think about addressing things like, are there doulas? Do we have programs to bring in African-American doulas to have them support the mom, and not just in birth, but 12 months postpartum as well? And so thinking again about this broader workforce. And so I've been thinking a lot about that and community health workers. So the role that hospitals play in bringing in lay and community health workers and and helping them provide a way to segue patients from underserved communities into hospital care. So these are the things, it's a diversifying of the workforce, but it's also addressing the broader community needs. And that's the message that our work has really been focused on.
Got it. Great. Really appreciate that. You made a comment during your last response about, as we think about supporting getting the appropriate levels of staffing and talent supply in our organizations, that we can't lose sight of the fact that there's an increased need to support those who are doing the work. And I think that's an issue that we ought to just spend a little bit of time on. As you mentioned, and as we discussed, many of the workforce challenges we're talking about today have just been amplified as a result of the pandemic. I think the one issue that I think many, if not most of us, would say was not necessarily as on our radar screen is sort of the resilience of our workforce. We were talking about burnout. We were talking about how do we support the workforce in a different way, to some extent pre-pandemic. But I think that's been one of the issues that's been so highlighted with many of us, and that, to some extent, one of the underpinnings of the Great Resignation in healthcare is burnout and lack of resiliency, and this sort of view that enough is enough given the challenge that our workforce has had to endure during a global health crisis. So maybe talk a little bit about this issue around workforce resilience, workforce support, and what our nation's hospitals and health systems ought to be thinking about to try to ensure that we're providing adequate support for our teams that are doing heroic work on a day-to-day basis.
Absolutely. Our workforce center is very much focused on wellness, and looking at it through the lens of sort of four different levels. There are obviously individual level wellness factors, and this is where most people have been focused, right? The National Academies of Medicine came out with a report saying, look, we need to move beyond just having these simple individual level focus. We need to be thinking about institutional factors. We need to be thinking about professional factors, and we need to think about societal factors that influence well-being, right? So moving beyond, sort of yoga and kudos and coffee and pizza parties to think about what are those institutional factors really where hospitals play an absolutely critical role. And that really gets to issues around sort of what we were just talking about, right? Redesigning workflows. There are ways that we can organize work that is more humane, that makes more sense. So do we engage the workforce themselves in helping us understand how could we better design the workforce? So documentation is a huge, huge burden.
Mm-hmm.
What if we had nurse scribes? Everyone talks about physicians. What if we had nurse scribes to reduce documentation burden for nurses? What if we asked nurses or other workers, what are you producing that you see of value?
Mm-hmm.
I think the answer might be different than what the hospital traditionally has been rewarding as value, because it is really getting people engaged in their work and helping them feel that they are producing value, right?
Right.
And I'm intrigued by this notion of stay surveys. Like, we always talk about exit surveys. Why'd you leave? Why? But did we ask the people who are staying why they stay and what motivates them to stay? These are all factors that contribute to daily and ongoing resilience. I feel mission driven. I feel valued. I feel compensated. I feel understood. I feel that my voice matters, that I have a role in this, that I'm in. So these are the things that we're looking at as well. And it's a little bit controversial, but I want to say we're also looking at issues around interprofessional issues and interprofessional violence. Like, there are cases where hierarchies and interprofessional violence make it very demoralizing to work in a place. And so those are the things that we got to think about how to address right up front.
This is a topic like this is one that we could talk about for most of the afternoon. And I know our audience will be highly interested, but they also will want to get back to supporting that workforce. So maybe with what you just described, let's just briefly talk a little bit about this, maybe explore a little more the notion of retention. Historically, we've always said that it's cheaper to keep a good team member than it is to recruit a new one. And every time for most of our organizations, our turnover rates are far higher than they've been historically. In some cases, 2 or 3x. And when we look at first year retention, we're seeing absolutely unacceptable levels of turnover. Which we know, like any complex problem, has a multifactorial basis. It's not one thing. It's not one bad leader, one bad organization. It's not completely unrealistic expectations about the job or working conditions or generational issues. It's a host of things. Maybe just the last thing we could just talk a bit about are any research that your center is producing that will give our listeners some insights on some of the best practices for retention, as you highlighted those stay surveys in your prior answer. So maybe we'll just spend a little bit of time on that, and then probably have to unfortunately close out our dialogue for this afternoon.
Sure, thanks. So I want to go back to this question of really making sure that we think about generational effects. And I think one of the things that our center has been studying is sort of seeing the workforce through the lens of what we call life course theory. What that means, and you just said it right, is that what a new nurse needs is different than what a middle career or older nurse. So let's just tackle those different kinds of, or social worker or physician. Let's just,
Sure.
Whatever the example. But that new nurse, we've been doing work on onboarding programs and the incredible role that onboarding plays, not just in building resilience and engagement, but also increasing productivity. One of the things I just want to underscore, going back to our entire conversation, is that it might sound pie in the sky to redesign an entire care delivery model, but if you do, it actually could save money. And if you actually invest in onboarding, it could save money and lower turnover. But we don't have as much evidence as we'd like. And so it's really important that we study these things. things. So onboarding, segmentation of compensation and benefits for the 26-year-old or 24-year-old who's still on mom and dad's health insurance gets that money in wages. That middle-aged group is looking at childcare. They're looking at commuter benefits. They're looking at contributing to their kids' college fund. They're looking at all sorts of things that are sort of mid-career. They may be looking for educational advancement. How do I move on to the next rung? What can the hospital do to support my career and my professional development? And that older worker, and I think this is particularly true in nursing, may be ready to move away from the bedside. Bedside's hard. It gets exhausting. And so maybe hospitals that are already partnering with educational institutions to send those providers over to be preceptors. We have a huge shortage of clinical preceptors. Can hospitals help, which will help the future pipeline and the long-term issues? So I think the hospitals can't go it alone here. They're in an ecosystem with employers, other employers and educators, and that sort of that retention piece has to be a group effort and has to be looked at across the life course for different interventions, I guess would be my takeaway.
Got it. Dr. Erin Fraher serves as the director of the Carolina Health Workforce Research Center. Erin, it's been a pleasure to spend some time with you. And I think it's safe for me to say on behalf of my colleagues across the American Hospital Association that we want to thank you for what you and your research center is doing to help us understand how we address the workforce challenges that we're facing today and tomorrow. We certainly appreciate all of your insights. Appreciate you sharing your time at our annual meeting last month. And we look forward to maybe chatting with you again at some point to get up-to-date info on best ways for us to be successful with our workforce. Thanks very much for joining me today. And to all our listeners and viewers, thank you for joining our Leadership Dialogue. Have a great afternoon.